Well, welcome everyone. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today for the first of this year's seminars as we continue on the eHealth Strategy Seminar Series. We also welcome those of you who are joining us from via the web. So this particular seminar, as we do with all of the Smarter Health seminars, are broadcast over the web. So if you can't get to us in person, we do welcome you this way as well. A very special welcome to our speaker, Ian McKillop, J.W. Graham Chair in Health Information Systems and Associate Professor in Computer Science and Health Studies and Gerontology. And as well, I'd like to acknowledge our sponsors for the seminar series. You'll see them listed across on the PowerPoint slide here. RIM, BlackBerry, Healthcare Information Management and Communications Canada, McKesson Canada, Smart Systems for Health Agency, and one of our newest partners, Borden, Ladner, and Gervais. Before we start, I have just a couple of announcements. The next seminar of this series will be Wednesday, February 22nd. Dominic Covey, Founding Director of the Waterloo Institute for Health Informatics Research, and NSERC AGFA Research Chair in Health Informatics, will be our guest speaker. The title of his talk is In Pursuit of the EHR Holy Grail, a Critical Situational Review. So I think that will be a very interesting talk. The next Health Informatics Boot Camp will be held in Toronto, April 5 to April 8th, a 4-day intensive boot camp. We're taking registrations. Go to our website and you can register right now. And finally, we're holding a 2-day intensive workshop for health privacy professionals March 16th, 17th at the University of Waterloo, and we're taking registrations for that as well. As you know, the purpose of this eHealth seminar series is to examine the Canadian Ontario eHealth strategies in detail. We have guest speakers that are looking at various initiatives here and across Canada regarding various strategies that are being developed, and this gives us a chance to evaluate them very critically. So we're pleased to have Ian here today to talk about initiatives in Ontario, and I'll let him speak more about that later. Our agenda for today, Ian will speak for about 45 to 50 minutes. That will be followed by a facilitated discussion, and finally, we'll have a special draw at the end, so I'm sure all of you are waiting for that. Without any further ado, I'll introduce David Johnson, President of the University of Waterloo, to introduce our speaker.
Thank you very much. Apropos of the special draw, Fraser, thank you very much for making it possible to have a special draw. I'm not sure that you all know what the special draw is, but it has something to do with RIM BlackBerry, and you'll be very pleased. You'll be especially pleased if you happen to be the one person whose card is drawn out of the hat. I asked if I could have a chance to introduce Ian. I have so much admiration for him, and we are so excited about the leadership he's providing to our university, so this is a special treat to me. Let me begin with this title, Drowning in Data. I mean, isn't this an appropriate title for the information age? And isn't our challenge, particularly as teachers, to learn how to ask the critical questions, critical thinking that goes back, I guess, at least until we began communicating with one another, and back to the Socratic method of developing that capacity of the critical question when there is so much evidence around, especially important today when our students, of course, are looking for answers at the push of the enter button on their computer, to have the reflective critical questions as we move from data to information to knowledge, and maybe if we're really lucky, up to wisdom, that band between knowledge and wisdom. One of the books that I work on regularly is a book called Communication Law in Canada. I read it with my former students. It's always former students that carry old professors. We update that every 4 months because that area of law is changing so rapidly. It's actually in loose leaf form. And we have a portion of it on broadcasting and a portion of it on receiving, as you'd expect in a communication law in Canada. And when you apply that to human beings, you find that some of us are a little better at broadcasting than we are at receiving. That has to do, again, with drowning in data and deciphering from the data the key themes that are necessary to move forward. One book I read on leadership on one occasion spoke about the importance of communication, good communication skills. Of course, the grand vision, the grand presentation, the positive presentation of ideas is so often emphasized, but in this book, the definition of great leadership was that of the individual who spent less time speaking at and more time listening and identifying the key questions, that was really the more essential quality of good communication, even than the presentation of the ideas. And so drowning in data is a very appropriate challenge for us in this particular area. I'm so pleased to hear Shirley mention the number of things going on, like the boot camp, the workshops, etc. There's a snowball effect occurring, which is very attractive in our university with respect to health informatics. In addition to the items that Chief just mentioned, last Thursday in this building, it may have been Friday, was the one-day presentation of the fourth-year electrical and computer engineering projects. These are projects on which a group of 4 or 5 students work for 3 terms, one entire year, very often coming out of their own work term, an idea that can be advanced and then into a project that ends up in some kind of new technology, new project. There are about 100 presented here. To use an expression of my children, it blew my mind, the quality, the power of these projects. And so many of them, guess what, were in health informatics, applying information technology to health. From these young minds who are so fertile and so creative and so powerful in what they are able to do. Well, let me turn to Ian's position, the J.W. Graham Research Chair in Health Information Systems. Some of you in this room will know all about Wes Graham. Frank Tompa, my old friend, is right there, a colleague of Wes's. When Wes passed away, his friends and his family established a trust in his name. It's the J.W. Graham Trust with about $5 million initially subscribed to it. I have the honor to chair that trust. We meet twice a year. And the terms of reference were crafted very much in Wes's interest. It was to cause the trust to function as a catalyst for new programs, new ideas in information technology, not with a view of funding them for a long, long time, as you would with an endowed chair or an endowed library collection, but to be able, year upon year, to identify 1 or 2 or 3 areas to provide the catalyst, the kick. And it was the Graham Trust that was the most important stimulus to us in the university to take what was so obviously an area of strength for us, health informatics, and to begin to put together the builders, the cross-disciplinary folks like Ian and Dominic and a few others who have given us very substantial leadership in this area and have had that great capacity to deal with ambiguities, to deal with the challenges of linking knowledge and expertise from across traditional disciplinary boundaries. So the Graham Trust, I think, is fulfilling its purpose magnificently. Ian's chair was one of the very first initiatives. It's very much in the image of Wes Graham, who always was starting great new things, and I think lived by the maxim of think big, start small, and scale up. And so it's a special pleasure for me to welcome Ian again to our university, to his leadership, and to celebrate the fact that he holds the Graham Chair, which is a remarkable feature of the University of Waterloo, remembering a very remarkable builder of this university. Ian, over to you. Thank you very much. Thank you. This needs to be put into page mode.
Great, thanks very much. Is my sound level okay for the people running sound? Okay, thanks. So yes, it's actually a very humbling honor to hold a position that was named after Wes Graham, particularly for myself as a graduate of this university. He's someone who certainly his presence and his influence on the school is well known to me, so it's kind of humbling to come back a number of years later and find myself able to work forward with some of the initiatives that he had the foresight to head up for us. So as was said, I actually hold a rather unique position, I guess, in some ways at the university. Often many of us as faculty members are domiciled in one faculty. I have the pleasure of being a part of two faculties, both David R. Cheriton School of Computer Science and also the Department of Health Studies and Gerontology and Applied Health Sciences, and provides me a wonderful opportunity to keep one foot in each of two of the very big parts of the kind of work that I do. Also part of the research group that I'm going to, or some of the research I'm going to talk with you today about is actually housed in a research cluster that we have here called Ideas for Health. So as you know, the Waterloo Institute for Health Informatics Research is a blanket organization that supports and encourages health informatics research across the campus. And then there's a group of us whose work focuses in areas of data and extracting evidence from data, and then I think one of Waterloo's wonderful strengths, wrapping applications around that to take evidence back out to the coalface, actually delivering solutions from a research perspective to the community that they find helpful. And that's a bit of what I hope to have a chance to show you today, both some policy things and also some of what we're actually up to here at Waterloo. So I'm delighted to have a chance to chat with you. So what I was hoping to look at this afternoon, I sort of put all three of these things here as an agenda, but I'm going to mix them as we go through. I sort of have three goals that I'd love to have a chance to share with you. First of all, to let you, for those of you who are new to it, see some of the challenges that we're currently facing. And I'm going to restrict my discussion today to Ontario's health system. I have the wonderful opportunity to work in a number of provinces, and would be happy to engage lively discussion with you as to whether or not the issues we face in Ontario, they're the same in other places, but maybe structured slightly differently. So I'll tell you a bit about what we're facing in Ontario from an information management standpoint, and information management's the broad area that I happen to work in. Let you know about some of the strategies that are being considered in Ontario. So this isn't a computer science talk per se. I'd like to take it up to a higher level and look at things from sort of a policy and planning level. What are the tough challenges that we're facing, and how are we thinking about tackling some of those? And I need to stress today that the ideas that I want to share with you, while they're informed by the fact that I have the wonderful opportunity to participate in many government planning committees and have an opportunity, as many professors do, to give input to the government, the comments that I'm sharing with you today are thoughts that I have that are informed by the area that I work in, and I'm not in any way suggesting that I'm here to represent official Ministry of Health policy. So sometimes I talk about the Ministry of Health, but I'm talking about them in a very generic way. As an outside observer looking in, these are some of the things that I know that they happen to be reflecting on. And I'd like to weave into this some of the work that I find to be quite exciting here that's now happening at Waterloo. The University of Waterloo, through our Health Informatics Initiative, is actually beginning to take quite an active role, certainly in Ontario, in delivering solutions out there that, I don't know what that's coming from. Oh, that's my, it's my helicopter in the background. Okay, so we'll get rid of my helicopter in the background. I work in air ambulance stuff, so I love the air ambulance pictures. So I thought no time at a university would be complete without a test, and therefore I often begin my discussions with people with a test. And so I brought some test questions with me today. So my first test question for you is, which town let's say, well, I'll say Canada, we could make that Ontario if you want. What town in Ontario has the best pediatric asthma management program? And by that I will suggest good asthma management means that in that town we see a very low incidence of pediatric asthma, because that can largely be avoided through good management. Where would that be? No, we don't have an answer.
Well,
a stacked audience. In fact, nobody knew. Nobody knew, because for years a question as simple as this was one that we couldn't answer. I would suggest to you that I don't believe there's a community in this province that isn't doing the very best that it can to try to provide quality care to the people who live in its community. And after some work where we tried to get into the data, and that is really the story, trying to bring reasoning to huge amounts of data, it was discovered that one of the best, I should be careful in choosing my words here, but one of the most successful towns in Ontario was Guelph. It actually came as a surprise even to them. So it wasn't that they were sitting there saying, my goodness, we're good. It was when the data was finally understood, even they said, wow, that's kind of cool. So let's say I told you it was Guelph. What would you do? You're a physician in Elliott Lake. If you have a child with asthma, maybe. I'll I'll suggest that what we do, and one of the wonderful things about medicine, about delivering care, and I should have prefaced my comments today. I will talk a lot about things from the perspective of hospital care and delivery of acute care, but trust me, my story is the same. When the University of Waterloo invited me to join them, I had to warn them. I said, I'm an acute care guy. I'm at home in the OR. I work with acute care data. And a lot of the expertise in this campus is actually in some other areas in the past, historically, some fantastic depth in population health and other areas. But they've been quite kind in inviting me in, and I'm now learning about their other fields. So today I'm going to talk a lot about my examples are drawn from my world of acute care, but I think the stories travel elsewhere. I suggest to you that if you were in Elliott Lake and you learned that the city of Guelph had one of the best pediatric asthma programs in the country, and you too wanted to deliver quality care to the children in your community, and this is largely a childhood condition, one of the reasons we watch it, I propose you get in the car and you go to Guelph and see what they're doing. Because one of the wonderful things about medicine is we learn by copying. I don't mean to in any way reduce the amazing educational skill sets of physicians and nurses and other care providers, but in many ways they learn by copying the success of others who have gone before them. So we'd all go and copy them and then take whatever we learned there back. As an aside on that story, when you got to Guelph and people got there and said, so what are you doing that's so amazing? How are you achieving these results? Even they, as I said, were a bit surprised to discover that they were achieving such good results. And the story is always so simple. At that time in that city, many of the local family doctors were taking their turn covering the ER. So the emergency department had a couple permanent ER doctors, but to a large extent, family docs who with ER qualifications were rotating through the ER. In the ER is where you meet children with acute pediatric asthma attacks. And a child in an asthma attack is often a signal of not optimal management in the community by the family medicine groups. So what the family docs got together with, they got together and they developed a citywide protocol. They said, okay, let's develop a standardized way of treating children across the whole city. Let's everybody implement it in our practice. And voila, the incidence of pediatric acute admissions plummeted. It's so simple. It's so simple. Now, I have to finish that story now that I've given a little plus to Guelph. I don't want, it's my hometown, so I don't want to make, sort of sound like I'm plugging for them. We also discovered, or they discovered during a bit of this work, that people felt that hospital, this is patient perceptions, that hospital maybe wasn't the cleanest hospital that they'd ever been in. And like many of you that might be from the hospital sector, they had an older physical plant. Frankly, I could clean your washroom right now and leave it perfectly clean, and if I asked you your perception of whether or not it was clean, you might tell me, not really. So the housekeepers were quite hurt. Here they were being credited for amazing pediatric asthma, and on the other part, they learned that the data was saying people thought their hospital was dirty. We did the same thing with them. They said, okay, well, if the problem is an old building, how come there's a hospital down south of Hamilton in Hagersville, I think it was, old site, built 1952, outstanding perceptions of cleanliness. It's an old building as well. And our cleaners at that time went down to Hagersville to see what they were doing and came away with some perfectly obvious ideas. It turned out down there that in Hagersville, no cleaner ever entered a room without learning the patient name. As they entered the room, they'd say, hello, Mrs. Smith, I'm Ian, and I'm here to clean your room today. I'm going to do your washroom for you. They'd clean the washroom, and as they left, they'd say, Mrs. Smith, there's nothing else I can do for you today. I just did your washroom. And what did they discover? Patients' perception of cleanliness went well up. And our local colleagues came back and instituted a very patient-focused, I mean, the whole hospital is patient-focused, but isn't that cool? Going right down to the housekeeper. To a housekeeper who thinks about, I'm going to call everybody by name. I make it a personal point here at the university to learn the name of the custodian who comes into my office. And I always make sure that I'm able to call that person by name, because I think that's a test of all of us contribute to the success of the organization. Anyway, some other questions. These get just as hard. These are classics for any of you who come from an organization. If you actually know this number, I'd love to hear it. I'll call you a liar the moment you give it to me. I apologize. Maybe there are some of us who actually have a great handle on this. In fact, how much we spend on IT is really hard to get to, often because we don't know how to measure it. We're approaching a model in Ontario, as many of you know, where we're going to introduce or have introduced local health integration networks. Officially, we don't have regions, but to a large extent, this is the idea of creating a regional focus on delivering quality care in which we tie together the various care providers. We're going to be very interested in learning who's doing a good job of integrating care. We don't know that right now. How much does it cost to deliver a baby at? I won't put anybody on the, we've got some hospitals in the room, but we could pick a local hospital and say how much does it cost. We often don't know. Now this is an interesting one because I actually worked in the development of some of the costing structures we have in the province, and why I say it's interesting is we actually could tell you how much it costs. The story I love to tell here is that when this work was done and the systems were built to do the costing, we had about 13 hospitals at the time that could generate, and this is actually a stunning indictment of our system. We only have around 10 hospitals right now in the province that are able to generate cost data for delivering care. We have, don't get me wrong, we have fantastic understanding of how much we spend on things. So there's no doubt that everyone knows exactly what they spend on nurses or what they spent on drugs. The real challenge is learning how much did we spend on Ian McKillop's broken arm and trying to take all of those pieces into it. And that becomes important for us as we try to make some rationalization decisions or decisions about effective funding. We had about 10 hospitals who were able to generate this number, and I was struck in looking at the data where we had one hospital, teaching type hospital, large community hospital, where it appeared to cost around $400 to deliver a baby. Natural vaginal delivery, so these would be uncomplicated births. My apologies to women in the room. I'm not saying that it's there's no effort involved. I'm just saying that this would be a birth in which there's not a lot of intervention required. The mother, in essence, does all the work, and we simply catch, put the baby in a towel, and give it to the mother to hug. Cost $400 at one hospital, a very similar hospital with a very similar, 26-year-old mother, healthy, the whole thing, where the cost appeared to be just under $4,000. And, my facetious comment at the time was either that other group of mothers is using far too many ice chips from the ice machine, because that's about the only consumable expense that was involved in the process, or I propose we have a problem with how we're assembling the data. And that's what we're looking at today. So my proposal to you is that we don't know the answers to many of these questions. And often when we do have an answer, or we think we know the answer, we really don't know. As somebody who works with the data, I'm always, I have a little saying that I borrowed from others. I say in healthcare we have tremendously precise and totally incorrect information in many areas. So that value for the baby, by the way, we had that data. People showed me that data at about 8 decimal places. That was $397.68973, because you can make that kind of division, and of course the arithmetic will generate those decimal points. So we have a sense of security, I think, sometimes in the data that we use to make our decisions, or the information that maybe isn't quite there. However, it's certainly not for lack of trying, certainly in the province of Ontario. And in fact, I want to give some credit here. I don't want to make this sound like I'm knocking everything that we're doing in terms of data collection. I think as Canadians, as many of you know, we should feel very proud about the fact that in the world we are actually quite leaders. We are leaders in developing national information system architectures, both that are designed to collect the kind of health data that one would need to make informed decisions about care planning, about allocation of resources, about effectiveness of the system, about efficiency of the system. So through the Canadian Institute for Health Information, which the government, or the provinces, I guess I shouldn't say the government, the provinces collaborated to form a few years ago, through Statistics Canada, we are a model country in the world that people come to look for how to organize and structure the data collection process. So it's not for lack of trying. But we actually do collect a fair amount of data. And it's, the stunning part is how much we do collect. Now, this next slide is one of my favorites. It's been generated, this was generated for some work that was done in Ontario. We got concerned in Ontario from an information management standpoint that we seem to have a lot of data. And we spent so much of our time moving data around that we actually never got to using it for anything. Or when we did use it for anything, we were never really sure which data we were supposed to be using for whatever it was that we were doing. This is the actual data flow map of where we move data in the province of Ontario in our health sector. Originating on the far side, they've asked me to remain boat anchored here, from the data originators through to, you'll see people like Information Holdings is the blue area in the middle. This is a stunning indictment of why we have challenges in finding information, why we have duplicated information, why we have incorrect information. And after the team spent about 4 weeks doing this, I actually joked with them and said, why did we waste 4 weeks at that? We should have just taken a whole bunch of boxes and drawn lines. We would have had the same effect. But if you have my slide, and you need to take the slide to about, you have to go to about 750% magnification. And when you get to that point, you will actually find that there are words in every single one of those boxes, and they are the actual words of that data repository or that data movement part. So clearly we have a problem, because with this kind of a data imagine being an information technology person coming in and you're being asked to build a data architecture that layers on top of that. And every time we do, we meet, of course, with all the challenges that those of you who work in information architecture would face. That's a pretty daunting thing. Now, of course, what's happened in the past, we've never shown the poor people the whole picture, right? So some poor person's working on a database or an information architecture component of that, and is actually possibly they've been shielded from seeing the whole picture, so they're quite thrilled that they're getting progress. But what they've actually done is perfect, this line here, which is now working very well. But of course, all the data that comes in and out of that's flawed. In fact, back-of-envelope calculation seems to be suggesting we're spending about $600 million a year in managing information, or just in Ontario. And I guess I'd counter that by saying, you know what, if we're getting $600 million in benefit, good for it. Then it's a well-invested amount of money. The scary part is that this appears to be rising on us about 25% faster than all the other costs that we're managing in the healthcare system. So our data management costs, the cost of moving this data, assembling this data, is going up quite fast compared to some of our other costs. I can't speak immediately to what's causing that. That could be a renewed interest in investment in information technology and networks and solutions. It could be a renewed interest in the need for information. Some of the work that I'm doing, you're seeing there's a real push to invest in getting information out. Certainly our projects, the stuff that we're working on, we're probably on some of the stuff I'm going to show you, we're probably at about $13 million in investment so far in just some of the stuff that I'm going to show you. So significant expense being made, and if we get benefit from it, that's great. The discharge abstract database, more colloquially known as the DAD, for those of you familiar with it, is a process by which we gather information about everybody's encounter in a hospital. There's a process of a group of professionals in the medical records department who tease out of that data, all those handwritten notes, everything the nurses and the doctors made about you. They tease out of that the key elements of what it is that you were in the hospital for, and we have a minimum data set that's maintained in Ottawa that is a picture of every single encounter somebody's had with our healthcare system. And there's always people wanting to collect new information there, and we believe at the moment it costs about $1 million just for somebody to say, let's collect this new piece of information. There's always a good reason for that new piece of information. I'm not doubting it. Sometimes I question it. When I was early in my career, I was invited to sit on the National Information Systems Architecture Steering Committee. And this group wasn't so much with the IS architecture. This group is the interprovincial committee that makes decisions about what data would be collected and how the schema will work in terms of how we organize that data. And most of the data in this particular task we were given related to either financial data about spending or revenues, and also what they call statistical data. How many patients went to emergency? How many procedures were performed? How many hours did nurses work? And we collect a few thousand pieces of this statistical data. The statisticians in the room wouldn't view this as statistic. It's data that doesn't have a dollar sign in front of it. I was invited to join this committee as the only academic on it, a junior academic just starting my career. I was thrilled. I thought, boy, I am going to sit at the table where the decisions are made for my country. This is an amazing place to be. One rep, BC, Alberta, one sheriff for every province. And I went to my first meeting, quite excited, and the first presentation was from a gentleman from Statistics Canada who had brought a proposal. So this is the committee that approves whether or not a piece of data will now be collected. He brought a proposal in which he wanted, in the existing data collection, there's actually, there is a measure in there, believe it or not, where they count how many kilograms of food would be consumed in a hospital, as well as how much they spent. So you can tell how much they spent, you can tell the total quantity of food that got consumed. And I think at the moment it might be divided by dairy products and something else. Anyway, this gentleman wanted to add new data elements to the master database, and he wanted to include data collection for every type of vegetable. He wanted to know how many kilograms of rutabagas were consumed in Ontario hospitals, how many carrots, how many potatoes, how much corn. I thought he was the morning entertainment. I was actually thinking, this is a great group. My goodness, they've got a sense of humor to think that they'd open a three-day meeting with just, this is cool. These people, they probably party hard at night as well. And he was about 30 minutes into it before I realized this man was deadly serious. Deadly serious. Now, to give him I want to defend him for a minute. He's from Statistics Canada. He's possibly from the part of the government that needs to make planning around our rutabaga inventories and the funding and support of farmers or our rutabaga industry. So I'm saying that in a serious way. There's probably somebody who needs to know how many rutabagas we eat. And here he saw, I mean, you and I aren't counting rutabagas at home, right? We're not filling out any forms on our rutabaga consumption. But in a hospital environment where we already have an information architecture designed to seamlessly collect all this data, he saw an opportunity to request that this data be added. His request was denied, but he was an example of, you know, now that I see this number, I'm sure it would have been $1 million across the system. In fact, maybe more than that. I can't imagine, Dennis, if I called you up at your hospital and said, how many potatoes did you use? And expected you to report on that, and if you didn't, to hold you to it. So these are, if you recognize the face up here, it's a wise fellow from information management years ago, Russell Ackoff, who developed these myths. These are all myths. He wrote a very famous paper in the 50s in which he was able to argue convincingly, and I believe it's still true today, that just because you have more information doesn't mean you make better decisions. Many managers don't need the information they want to make the decisions they're making. He believes you do need to know how the system works in order to use it. A lot of people felt it's a black box. Doesn't matter how the computer works. Wait for the answer. All I need to know is what went in and what came out. And he interestingly also showed that sometimes the wide sharing of information actually degrades decision-making ability. So I hold those for you to remember that these aren't true, and therefore, what should we do? Well, it's interesting. One of my favorite expressions is that we need smarter data to make smarter decisions, and it fits so well, coincidentally, with the theme of the Waterloo Institute for Health Informatics Research seminar series, the Smarter Health series, because that's what we need. We need smarter information. We've got to make smarter decisions, and we're going to need a plan to get there. And that means we're probably going to have to equip some people with tools to do that. So I've been telling a fairly, I hope not too dreary a tale. I've tried to put in some examples of success, and I also want to balance that now and say, as much as I've said we've got a real challenge ahead of us, the great news is this challenge has been recognized and it's being tackled aggressively by a number of people, from organizations like the provinces to a group called the Joint Policy and Planning Committee in Ontario, through to a group I'm going to talk a bit about today, the Hospital Report Research Collaborative, a group of about 10 universities, 35 researchers that are tackling some of this information dissemination challenge. So let me try and lay out a potential plan for us. Where might we go that would help us overcome the challenges that I've tried to lay out for us this morning? And it's a 4-step plan that I'm going to propose to you. It's something a number of us have been talking about for a while. It's actually beginning to form a part of the thinking in Ontario through, some of you may know, we have the Premier has set up a number of these health results teams focused on specific areas. So there's one on wait times that's working very hard to manage wait times. And the team that I'm most actively involved with is the health results team on information management. So they're very actively thinking about this. And in fact, my presentation's already a bit out of date because, as you may know, on Tuesday last, we made some of the largest changes that have ever happened in the structure of ministry in Ontario when the Ministry of Health was reorganized to actually support some of the things I'm going to share with you here. So what do we need first of all? Well, I propose to you we need to produce better data. That's smarter data. We need data about cost, quality, and resources, and we need to think about what that is. And the key part at the end, we've always wanted this first part in blue. We have to do that in a way that reduces the burden. We have to stop overwhelming people with the process of collecting data so they could actually maybe begin to use it. I always like to talk about wonky data. I have lots of examples of wonky data. So just from my part of my career, I have a hospital that I could show you that somehow used $1 million more in supplies than they ever received. You know, I suspect that's just a little glitch in the inventory system. I think people were taking things out and nobody ever recorded that it came in. That's probably easy to fix. However, $10,000 to drop into the clinic, that's a bit excessive, so that sort of fits with my model earlier of the cost of a baby. I have an interesting hospital where it appears that patients are actually sending in money ahead of time for private rooms, just in case. I don't know. I haven't done that at my local hospital, but again, you know, there may be a perfectly. I'm not saying these things are wrong. I'm just saying there may be perfectly rational explanations for these, but these are what I call wonky data. And if this data is there, if that's the data, imagine the information and the decisions we make on that. It all gets compromised all the way down the road because we start with bad information. And I'll suggest to you that maybe a bit of what's happening there is just the reporting burden. I'm going to be sympathetic now to the people who actually have to collect all of these data. They are so overwhelmed by collecting it that should we be surprised? We shouldn't be surprised that at times things get written in the wrong place, or you've got so much data you can't actually see the wonky data because you're looking at all the other parts. So we need to think of some tools to help them spot that. And then, of course, the part that is in game theory, there's all sorts of data challenges just created by the fact that, and I'm going to say this in a positive way, I have yet to meet a chief executive officer, a chief of staff, or anybody in the system who isn't trying to do the very best they can for their community. The challenge we have in our system is it's a pie-cutting exercise. So every $10 that comes to Kitchener-Waterloo is $10 that didn't go to somebody else. So what we often find is when you're asked to collect data, and if you understand or can guess or game what the data is going to be used for, people will maximize their benefit with the data to place their community in as positive a light as they can. Some examples to illustrate that. Some of you know a few years ago we had to cancel it. We have a fantastic system in Canada for grouping patients. The CMGs, case management groups, paralleled after a somewhat similar system in the United States. And what this system does, remember I talked about the district abstract database. When your data goes to Ottawa, there are experts who say, that person had their appendix out. That was an appendectomy. And we can take all the people who got an appendectomy and we can put them in the same pail and we can say they should all be about the same. And we do group it by age. So we have old people with appendectomies, middle people with appendectomies, and children. And somebody raised the point, you know what? All appendectomies aren't the same. What about somebody who has diabetes and is in a wheelchair and they have an appendectomy? One shouldn't expect the cost of providing care to them to be the same as somebody who's 26 years old and healthy. And that was recognized as a very bona fide explanation. There are things that complicate this treatment. And Canada introduced something called the Plex overlay, a fantastic way of saying, let's take that appendectomy patient and let's divide them into 4 categories. The person who has no complicating conditions that would in any way impact their recovery, that's just an ordinary appendectomy, 35 years old, all the way up to somebody who has life-threatening complications. So maybe you needed an appendectomy, but you're actually in there because you're in a car accident and there's head trauma, all sorts of other things. That's a bit different appendectomy. And the system was you could mark off then medical records people were asked to indicate, or through physicians were asked to indicate, any complicating factors that would make this person cost more to treat than the next person, although they're both appendectomies. And of course the idea was, if these people really were, if I was a hospital and I had just 100 ordinary 26-year-olds getting an appendectomy out laparoscopically, tiny little incision, take it out, voila, go home the same day, versus another hospital that did 100 where these were very, very complicated, major surgery type things, that we could see that difference. Well, it was intriguing when the Plex overlay came in that in Ontario, the severity of acuity, the sickness of patients just seemed to go up and up and up. One of 2 things could be happening. It could be that our old system wasn't correctly reflecting the level of acuity in the population, or maybe people were exploring the ways to ensure that their patients were, if there was a choice to categorize you, how I could categorize you as the sickest. An example I had somebody show me, one of the things you could get some extra points for is if you had low sodium levels. And you'd see a patient with 15 sodium tests that were negative and 1 that was positive, bang, they'd show up on the list for high sodium and they'd get the extra reward for being high sodium. I work in hips and knees, orthopedic surgery. I was intrigued to learn that almost everybody who got a hip and knee replacement was being coded for having difficulty walking. You're supposed to code the things that were complicated. We fully expect somebody with a new hip to have a little bit of difficulty walking. In fact, it would be stunning if they didn't have difficulty walking. We should adjust there. So some of the ideas that are being explored. We need to reduce this data collection burden. We have to get rid of that picture that I showed you. We have to streamline that. There's some thought about creating data management partnerships. There's some thoughts about helping people create data blitzes, a process by which we look at everybody's data together and say, are we seeing anything strange here? We've actually already done that in the clinical world. This is the old picture on the right, or on the left, my left, I guess, here, my right. And here's a bit of where it's been early streamlining. Now, I've also teased the team and said, have we just drawn the lines neater here? And they've assured me that, in fact, there's a few hundred less lines on the right-hand side than there were on the left. The key to this part is building a central data repository and data warehousing. A lot of stuff that's already struck our colleagues in industry who know the value of this, but we have not yet built or had not yet built any central data repository into which everybody would tap when they need data. We were keeping multiple copies. Step 2, we need to think about supporting evidence-based decisions. And particularly with these local health integration networks coming online, we are going to have to provide, there's a whole whack of people out there now who are going to need support to make decisions in an environment we've never had in Ontario before. What do we face at the moment? Well, across the Ministry of Health, it turns out different parts of the ministry use different decision support tools for the same thing. So you can actually get you can get different answers from different people depending upon which decision support tools they're using and which data they're using. And any of you from the hospital sector, you know exactly what I'm talking about here. In many cases, we've got multiple points of contact for people, whether you're complex continuing care, rehab, long-term care. The place you access the system is different. And often what one person knows isn't told to another. And we're discovering many provider organizations don't have the data they need to support decision making. What's being discussed? Not to say that any of these will happen. Some of them are already coming close to happening. The first one certainly has. Thinking about information management from the perspective of focusing some access points for information for the local health integration networks. I think quite exciting, thinking much longer term. In healthcare, we've had a habit of planning 12-month rolling windows. We usually don't get the 12-month rolling window done until about 8 months in, by which time it's already time to think of the next 12-month rolling window. So effectively, I apologize if it sounds harsh, we don't really do the kind of planning we should with the information we have. And there's some debate about, if we're actually trying to manage this much data, which we want to convert into knowledge, what about a knowledge management system for the province of Ontario in which we could put all of this expertise and then people could access it? The university community is also responding. This is a project that the University of Waterloo is very actively involved in. This is a project that's coordinated through the University of Toronto and involves a number of universities, researchers, and hospitals. And our role, as I'll show you in a second, deals with something that we're quite uniquely positioned to help with, a lot of the software and e-tool sides, the computer science side of it. If you haven't heard of the Hospital Report Collaborative, this is something that was begun back in 1997. It was headed by Professor Ross Baker at Toronto. The idea at the time was my story about asthma. Nobody in the province knew nobody knew where excellence was. And the idea was, could we build a system where we could for once identify where's excellence? And the goal was, once we identify excellence, everybody could go and copy it. And this has now emerged as one of the largest performance improvement initiatives in the world. And we're quite honored to think that that's here in Canada. We have people from all over the world coming to see what we did in Canada. And what's unique about it, lots of people have done performance reporting. My goodness, the Americans have some amazing systems down there. What's really unique about this system, it's 100% voluntary and full disclosed access. So a lot of the systems that are out there are private data collection, available only to people who pay to get the data. Or ministry or government systems are designed to find fault. The National Health Authority in Britain, in my opinion, built a similar system. It was all about finding fault. Who's killing the most people? Let's list their names and shame them into killing less people. Even in the United States, you can go and look up a doctor's name, and what you find out for that doctor is how many adverse events they had and how careless they are, as opposed to thinking about what I'd really like to do is find the doctors who are having amazing outcomes, and then maybe the person who's having a few adverse event outcomes could go and learn from that person. So a very different focus. The exciting part for us is 2005 marks a milestone, launching e-tools. So these things were largely print-based before. Am I okay till 4? Okay. A CEO gave us this quote, I love it. He says, I'm sitting on a gold mine of data, but nobody sent me any miners. And I think what we're trying to do in Ontario now is to begin the mining process. So here's my little picture of a mine. So the first tool that got developed with the University Collaborative for a number of years, we've been producing these printed books. They're very colorful and they look nice on the bookshelf, but to be quite fair and even be critical of my own work, they're pretty much outdated by the time you get your hands on one. So a hospital could say, wow, in fact, many hospitals told me it's like winning a prize. You didn't know it was coming? You got this great prize. My story about my own city discovering that they had an amazing asthma program. Well, they'd had an amazing asthma program for 1.5 years before we told them. Right? So they were saying, well, that's nice to hear, but it's not really anything we could have affected. So one of the legitimate criticisms we've had is how to speed it up, how to build a tool that was more real time. The other problem with print media is you can only look at things the way that we choose to present it to you, and we're quite restricted. I let you compare your hospital to other hospitals that I decided, and my research colleagues decided were similar to yours. You might not feel that way. If you were Grand River Hospital and you wanted to find somebody to compare yourself to, you might say, the real person I want to put myself up against is London Health Sciences. I don't know. And I might not have, because of the way we grouped it with our research group, we might not have put that in there. So this is an online tool Very common idea that's out there. Trying to build user-friendly environments for performance reporting using models. There's no rocket science here. This is stuff that the industry's been doing quite a while, building drill-down capacity in terms of decision support tools, decision support systems. So the tool, and this tool actually runs out of the University of Waterloo, so we host and maintain this now for the whole province. So all across the province, every hospital who's attempting to monitor or manage their performance is now accessing a resource here at the University of Waterloo. And it's classic. There's many products that do this. We actually went out for an RFP, bought a product from a vendor that the vendor agreed to tailor for us in classic 80-20 rule. They had no idea what they were getting into. This is the vendor that actually already supports the decision support tool for the Ontario Fire Marshal's Office, the Ontario Ministry of Education, the Ontario Provincial Police. Every single detachment in the province is on this thing. And then they came and tried it in hospitals. And I think we've pretty much ground them right. I think the lights are dimming at the company that helped us with this. However, they've had to make a lot of adaptations for the unique challenges that we face in healthcare. So again, it's your classic sort of decision support tool. I can now say I want to look at just my hospital. I can choose if I'm a manager in the hospital to say I want to look at all my sites. And I can also look at the regions of hospitals, which I can decide. This is a key element of the Ontario program. The data on every single hospital in the province is included and publicly available to everybody. And other jurisdictions are shocked that we've been able to achieve this level of support. And I can't speak highly enough about the amazing support that we have from Ontario's hospital community. There are some non-participating hospitals. I can count them on one hand. And in almost all cases, they are very tiny, remote, geographically isolated hospitals where some of the burden in terms of, let's say, learning how their patients think about them is too much overhead for them with the staff they have there. But you can see even in this list, it's alphabetical, everything from Alexandra Hospital down to Brant County. If we could scroll down, we'd find them all. So the power of this tool is I can now choose hospitals that I would like to put myself up against. So they said not to move, but I'll just point here and come back. Here I'm saying, okay, in the past I had to confine myself to comparing myself to other hospitals that the research team said were my peers. Here I'm saying I would like to compare myself to other hospitals where they have acute care. They also offer complex continuing care. They not only offer complex continuing care, but they do a lot of it, so I'm setting the patient days large. They have an emergency department because that drives a lot of costs. They also have rehabilitation. They have revenues that fall in a certain target and size. And what's fallen out, it turns out there's only 4 hospitals in the province that meet those criteria. So now I'm actually, if I was one of these, I'm going to put myself up against my peers. And so I won't just skip that. There's some ability to look at time tracking, classic trending. I can drill down. So here I have, I've selected these hospitals and said, I'm going to show you some data that I can disclose publicly here in a forum. There's nothing secret here. I want to learn about whether or not they're in the hole, are they in a deficit, and have they got, how's their financial stability. So I'm drilling down, and I'm bringing up information now on these hospitals. So kind of crude. We've actually changed the interface since this was the OPP interface, and we tried to make it a bit more user-friendly. But classic decision support tool, nothing new here, but very, very new in the health sector. For the very first time, empowering managers across a whole hospital, from their board of directors to whatever level they want to use this at, with the ability to drill down. Lots of numeric, graphical capability. If you just focus on the far side at the moment, uses a classic stoplight interface. So at this particular hospital, we're looking at the hospital in the province of Ontario. There are a set of performance indicators that they're choosing to track. In the very top box, we see 3 with the red on top of it. That means 3 of their targets are not being met. 10 are within some border that they've set for themselves, and they've got 33 of the things they're tracking that are going very well. And in fact, if we drill down, we'll see that the 3 red ones at the moment are actually in their patient. They must have 3 patient satisfaction measures that aren't on target. We get classic decision support, executive support tools. They all work this way. I'm not showing anything that's new. Of course, they all come with speedometers, so we put in speedometers. As people expect. The OPP don't have speedometers, so we're sure they're going to ask for them now that they discover that we've got them, but the speedometers were a big hit. And the significance in the speedometers, again, we can show people if your needle's in the green, you're within your target. They're also seeing here, if I step out, they're seeing the average and means for other hospitals in the province so they can sort of benchmark themselves against colleagues. So as I said, this team that I'm a part of, Ideas for Health, which is the group that's involved in thinking about how to take data, turning it into evidence, and then wrapping applications around it, we have acquired responsibility for this product out of the University of Toronto, is where we originally had it based. We've migrated all of our electronic tools here to UW. And I'll show you, I'll show you how to get into it if you're interested. Step 3, measure performance quickly. We can't measure what we don't manage, or we can't manage what we don't measure. The old adage. Lots of challenges here. We've got all sorts of sector-specific performance. In fact, I just showed you some, our speedometers. They look very colorful, but they don't help you at all manage at the system level. We're also moving into an environment where people are really interested in tying resources. In fact, this is the accountability agreement. It's not Mr. McGinty that said no empty promises. I've added that, but Mr. McGinty's been very clear that he's going to hold people accountable for delivering, and he's working on the healthcare sector first. I expect we're next in universities, or somebody's next. And there's a lack of tools to measure performance. So what are we thinking about, or what is being thought about at the policy and strategy level? I think a lot of people make a mistake here who are in the performance measurement area. They're busy. They decide what to measure before they decide why to measure it. And I think the province is going through a really nice renaissance of stepping back and saying, what's our strategy? Let's do that first. Then we'll build a tool to measure it. Versus keep going into meetings where everybody wants to start measuring. We should count how many nurses were away on Tuesday. That's because somebody's in charge of nurses on Tuesday. That's an important number to them. But it doesn't really fit with overall strategy. And at the bottom here, another tool that's come up. One of the criticisms, legitimate, of the e-scorecard that I showed you is that just like the books, it's very dynamic. You can slice and you can dice, but you can't slice and dice until a year after the data has been collected. So it takes a whole year for CIHI and the federal government to process the data, make it look nice. They send it to us, then we make it look pretty. We put some speedometers on it. That was your speed last year, which really, again, doesn't help you with your speed this year. So we've developed another tool here at the University of Waterloo, our wizard for hospital indicator calculation, the WIC. And it's a really good example of how the research community can respond to the public community saying, so the hospitals and providers said to us, your e-scorecard is fantastic, but I need data today. I need answers right now, particularly in an environment where I'm going to be held accountable, and all the CEOs, CFOs, they're all now going to be held accountable for delivering on certain performance targets. How do I know my performance target? I don't want to wait a year later to learn. So the Research Collaborative got together, and we built a tool that we can actually deploy and give to the hospital, where they can now calculate all of the values that are in the fancy year-end tool themselves, but they can calculate it locally, real time. And starting next month, this is a real new change for us. The tool from the university here is going to actually be used by hospitals to track whether or not they're achieving their provincially mandated targets. Comes with a bunch of modules. I don't need to look at all the screenshots with you, but there's a button for each one. Emergency department, rehab are coming online. We're developing those ones now. The hospital accountability one comes online next month. Here's an example of getting in. So here's a CEO that's going to go through, or a manager in a finance department, or if we could also get to the clinical side, and they're choosing. These are actual things the province is requiring them to be accountable for. They're choosing the ones that they want to see the answers to. And we're able to generate in real time, as fast as they can load their data in, values for the hospital. What's really unique about this product is the financial stuff might excite me some days, but that only excites the financial people. It also has all the clinical indicators in it. So let's say you discover that your asthma management isn't quite on target. What this tool will actually let you do, because it's your data, is once we tell you that your asthma is off target, you can drill right down and actually get the chart numbers of the actual patients who are contributing to the fact that your asthma results aren't quite at the provincial target. And then you could go in and look at those patients, and you might decide there's a logical reason for that, or you might decide, wow, these are patients where we could have managed things differently. So this drills right down to the chart level. And because it's managed by the hospital locally, it doesn't involve us at the university. We give them the tool. They run it locally. They're able to run it as quickly as they can load data. If you are a hospital in Ontario who's participating in the report, I certainly encourage you to go and take a look at the tools. They're available to all of you to use. I'll give you this is the new website, the one that runs here at Waterloo. If you go to this location, you actually get our old one at the moment. So if you go hospitalreport.uwaterloo.ca, you'll get taken to this. And this will be the live site probably in about 14 days. We just have a couple of names and things to clean up for people. If you go there, you'll be asked for a password and a user ID. That's just to stop the indexing from working. It's a high secure site. The user ID is hospital, and the password is report. That's, again, just to stop. But you're welcome to, again, within a week, that will be the public face, but you have to add the U-Waterloo to take a look at that. And lastly, to wind up, step 4, building trust, something that I think we really need to focus on, building trust with our data providers. Our challenges, accountability means different things to some people. To some people, it means doing the right thing. To other people, it means being punished if I don't do the right thing. we have a lot of information management strategies that are inconsistent with it. In fact, we often collect data for one purpose. We tell you we need the data for this, and then we go and use it for something else. And that doesn't do us any good at building trust. And certainly our system, it's often, this is a limousine. I did some work a few years ago where I tried to understand, we published some work on how hospitals are funded or how the funding decisions are made across the country. And there are some provinces where it's a very rigorous mathematical, very rigorous mathematical method we could debate whether it's equitable. And in some provinces, it was quite obvious that there was no method. The minister just decided how much money to give to people. So we called that our back of limousine method. We were criticized for that by one of the provinces that used that. They didn't doubt that they used it. They were perfectly okay with saying that's the truth, but it's a bit harsh. So we've renamed that the ministerial discretion method, which means whoever argues with the minister the most gets the most money. So what are some of the things to just close off this part that are being looked at? Building a consistent framework, trying to share target setting, which is part of the negotiation process right now in Ontario versus up until now people have been told what to do, and trying to really encourage a culture where decisions are made that are informed by data. So my thoughts to all of you, my challenge to you, is either we learn to manage this information, we either take control of this, or it is going to take control of us. I can only withstand, I held off the rutabaga guy once, but if he comes back again, he might win. And that's a challenge for us. And we need to think about what's the data we need, what's the information we need, and I think a wonderful challenge for those of us in the research community, how to take that information, distill it, and deliver it to the coal face so that the people who need to make decisions can make them. And I challenge you because I think that's a role for us in the research community, but it's also a vital role for you as providers and those of you from industry in helping bring that to life. And I suggest to you, if you're able to do that, we'll all be better for it. We'll leave the system in better condition for our kids than we found it as we moved into it. So thank you very much for your attention.
Now we have an opportunity for discussion. I learned something in what's-his-name's talk. That was on your slide, Ian. Ian would be, I'm sure, welcome questions and comments. We have some people from hospitals here, and an opportunity to bring up topics that might be of interest to you, as well as to address what was discussed here. So questions and comments from people in the audience. Give us a chance, too, to get the microphone to you if you could. So put your hand up early, and I'll try to serve each of you. Questions and comments.
When you use the mic, you just hold it to you, towards you, please.
Dennis Egan, Grand River Hospital. My question is, in some of our more mature, if you can call it that, information systems, I guess our cost per case one, you mentioned how much does it cost to deliver a baby. One of the concerns that I have is that in Ontario, it's a zero-sum game. And we've been tracking these over time. And what happens by definition, half are high and half are low, or half are above the average, half are below the average. And to me, what's missing, like I have no problem as a leader, challenging my people to deliver a cost comparable to others. But in the Ontario context, when it's a zero-sum game, we may be just all ratcheting ourselves into the ground. And I think one of the things that's lacking, and I'd be interested in your comment, is a frame of reference, i.e., what does it cost to deliver a baby in Manitoba or the UK or the US? And really I guess that gets at not necessarily my accountability, but perhaps the Minister of Health in Ontario, but that's something that's missing and that I think, is a reason for people to kind of want to walk away from the data because we're not really sure it's heading us in the right direction. So I'd be interested in your concept, but more meaningful frame of reference that we can challenge our people with. Couldn't agree with you more. And in fact, a very legitimate criticism of the work that despite the fact people say, wow, you built the largest performance tracking system in the world, it has two major shortcomings. One is the timeliness of the data. By the time we actually get data to you, it's quite late. And the second challenge is we haven't got a clue in the world what is, for many areas, good performance. So I told you that this story about Guelph and how it was decided that, in fact, they had some of the best asthma management outcomes in the province. But that doesn't mean that the others who are below, your point's right on, that in the system of averages, half of us mathematically have to be above the average and half of us will be below. And therefore, there's a real push on now to say we need to abolish that. We had some experience at learning how to measure performance where the only target we could work to was what's the mean or what's the average, and we can say you're above it or you're below it.
and move instead to understanding what's good performance. What's an acceptable benchmark? And you're right. I'd be thrilled to learn that every single hospital in this province was, in fact, from an asthma management standpoint, experiencing more than adequate, excellent results in asthma. And we shouldn't then be taking arbitrarily, one standard deviation worth of them and saying, well, you're the weak ones, because you're right. It just creates ratcheting. So that actually is a big part of the research agenda that's now moving forward. The interesting part is in finance. There actually seems to be the area where we're having better traction, working with CFOs and CEOs to decide what is good performance. So there is now targets for margin and current ratio that's been proposed by the field, and those will become the new targets and not the average. In clinical areas like, there's that Ottawa limb management race score. So there are some areas, but you're absolutely right. Until we do that, if we're going to measure you based on average, I think all that did was make people think about performance. Now we need to put that aside and decide who is performing well. And if we're all doing poorly, we all want to pull up our socks. I don't want, it's the same story we talk about professors. If I told you that University X had the best professors in the world, but in fact they were all worse than some other university, wouldn't you like them to learn a bit from the others? Meanwhile, if you actually had the very best professors in the whole world, would you really like to invite the bottom 50 to leave just because they're the bottom 50? It's a point well made.
Other questions? I have a quick one. Obviously, in the institutions, you have a variety of, I'll call it creativity with regard to data. What's done to ensure that what comes in is the real stuff?
A huge amount. And in fact, one might argue that's even part of the challenge that we face. So as hospitals submit data, there is a massive process that goes through to try and decide, does that data look reasonable? And that's largely done with doing line-by-line type edit checks. So if you reported that you had nurses, you paid nurses money, well, that must mean somewhere else you've got how many hours they work. So if that's missing, a little red flag comes up. This is actually an exciting area, I think, at the University of Waterloo. I'm trying to encourage some of my colleagues to look at. We now have such large amounts of data coming in that the ability to go line by line by line and find all the relationships is taxing the system. And I have some colleagues here who work in the area of, I'm trying to say, if we knew this was a good set of data, if we could somehow decide that was good, could we use techniques to take another blob of data and say, that data must be good too because it looks like this data? Because at the moment they try to do it line by line. They have these data blitzes. They pour effort into it. And you're absolutely right, Dominic. At the end of the day, after 5,000 checks, somebody discovers that, somebody didn't have any babies, or somebody had numbers for birthing, but they didn't even have a birthing program. But they had numbers for birthing. So,
I guess the follow-up question on that is there actual work going on in the area of data mining? Or is that a future? I mean, where is that right now within the ministry?
I can't speak for within the ministry. I'm going to suggest from the lens that I look through that we probably aren't quite at mining the data yet because we haven't figured out how to warehouse it. But maybe once we get that part figured out, we might be able to use some of those tools.
Thanks. This is sort of a philosophic question. I'm interested in this question because I put it to a bunch of students today, and we were talking about how healthcare has sort of lagged behind other industries in picking up both on investment in IT, but also in data management. And these students, third-year business students, all said to me, well, it's because number one, they haven't made the investment financially. And number two, that they believed it was because there wasn't a profit motive driving this industry. And I was curious about what your opinion on that was and whether, in fact, collecting data is sufficient. Will people, if they don't have any imperative to use it to be able to be accountable to a number of different stakeholders, will it go further and quickly enough?
It's an excellent point. First, I want to come back to, I've been telling some stories out of school about the challenges we have. I want to be clear that we have excellent information in the province on how much we spend on healthcare. We have excellent information about who got what healthcare. So that data is collected. And there are many hospitals that internally have put huge resources into saying they understand the value of this information. They could make better decisions if they spent some time understanding it. You know, the profit-motivated one maybe is correct. I tell a story in my class about if I was the chief financial officer at Ford Motor Company and I went in to see the CEO, and the CEO said, "Ian, what does it cost to make a Freestar van?" And I said, "I haven't got a clue, but boy, people really like them and they're all lined up for them," I'd probably be fired. But in a hospital sector, to defend them, you know, what does it cost to deliver a baby? Well, I might be able to make some decisions that would put me in a better state if I knew that. But you know what? It doesn't change how many women in Kitchener-Waterloo are pregnant and are popping in to have they're dropping by. I shouldn't say my choice of words. You know, so I think the other thing that I say, and I say this with respect, I am stunned and with respect at the skill that the senior management people have in our health sector, who frankly are able to successfully manage in the absence of information that any other sector would have insisted having. So I haven't had a chance to run a large healthcare facility, but as a as sort of a follower of the science like you, these people have developed amazing ways to cope in the absence of information that other people would have. So we have a culture, I'll boldly suggest, where for the next generation we need to make them data informed. We have to help them understand what they could do if we started to provide some of that data and some of that information. I don't think we need to go to profit motivation. I think we need to have an environment in which data is seen as an effective way to make decisions. Doctors, just in the last 10 years, are only getting to that, right? I mean, you talk a doctor, if you go meet a 60-year-old doctor who went to school when they went to school, many of them are still working on, I mean, they read magazines. I'm not saying they don't stay current, but, you know, they're carrying it all in their head. Go meet a doctor coming out of McMaster today, and they're scary because every time you ask them something, they want to look it up because their training is much more data-driven. It's that evidence-based model. Go and find out what the latest thing is. I think we'll see a change in our system.
Okay, we actually have 3 questions from the web. The first is from Dahlia Fayek. She asks, what's the current direction to distribute electronic health records in Ontario? Do they belong to the hospitals who generate them, or they will be centralized in data centers across the province?
Well, first, I don't feel qualified to talk about the electronic health record per se and the legal issues of who owns them. That would be someone with more knowledge than I have about that field. There's certainly large work going into building an electronic health record concept across the country. The work that we're looking at here is not actually, this would be even more data to my spaghetti diagram. All of those spaghetti lines represent data that has been extracted from or relates to a specific health record, but it's not actually that. There was no health record of a person moving around on that screen. What might have been moving around that screen was a physician billing amount for when somebody got an encounter, or the fact that you were in the emergency department and you received this treatment. So those are good questions, and I'd actually look forward to learning the answer to them at some point.
Okay, the second question is from Carla Cockerline. She asks, are you aware of any initiatives that focus specifically on data collection in home health care delivery?
Yes, and in fact, some exciting initiatives that I hope we might be able to borrow from some other places around the world. There's an amazing program right now in Sweden called Care at Home, or Home Care. Care at Home, I think. It's got the @ like as in an email address. And they're actually doing point of care data collection, which then feeds into the kind of broader perspective data that we're looking at here. And there's been discussions of how we would facilitate that in Ontario. And again, the University of Waterloo is actually in a very unique position because the inter-array instruments that are often used for those assessments are based on this campus as well.
And the final question we have here is from Retta Fayek. She asks, where in the system and when would the patient medical information be linked to drug delivery channels, i.e. pharmaceuticals? Or sorry, pharmacies.
Yeah. Again, that deals much more in my understanding of where the electronic health record and the electronic health summary will work through Canada Health Infoway. And that would be another whole layer that sits outside of this. So my discussion today has been about the administrative data and the clinical data that is abstracted out of your actual medical record. But that handwritten medical record is another whole not waiting to be cracked. And in fact, my colleague Dominic Covey is one of the people who spends his days thinking about those issues, right? Or sort of in terms of how the electronic health record may come to fruition. So.
Roy Cameron. Ian, I'm curious about how, as a University of Waterloo faculty member, you see yourself making distinctions between what a faculty member does versus what somebody working in the system or a consultant to the system would do. I think many of us who are getting involved in work where research is integrated with policy and practice have to struggle with figuring out where this line is.
Absolutely.
What are your thoughts?
Yeah, absolutely. And in fact, it's been, as you can imagine, a topic of much discussion for us. And I wasn't clear about that. Thank you for letting me have an opportunity to explain that. Certainly, some of the work that we're doing, I think some of the early work that we do, our argument has been that as researchers, our goal is to develop the methodologies, the tools that allow this kind of work to happen. And once we've proven and developed the methodologies, we actually pass it off. So in fact, the first few years of the hospital report were done completely within the university community by university faculty members and research officers. Effective 2005, the Canadian Institute for Health Information has taken over all replication of our methods. So all the work has left the university in terms of calculating indicators. So we developed the science of how to do it, the science of how to measure it, the science of how to record it, and now others do it and they actually feed back the data. The e-scorecard is a good example. Our research angle there is I'm interested in those tools from the perspective of how to best support the decision-making process of people in the system, how best to deliver that information, how best to ensure it's accurate. And I think once we have those methods and things done, you're absolutely right, Roy, we'll step aside. That will be passed to somebody else. Because myself and all my colleagues, we get to the point where I said, there's no way I want to work out your asthma methods. That's just once or twice when we're developing statistical methods, it's kind of cool, but after that, it's replication. That's the distinction we've made. The research is designing and developing and proving. Once it's developed and proven or accepted, we pass it off to other agencies such as ISIS, CIHI, who do it. So I was taking credit for things there that I actually shouldn't take credit for. So all the data in the e-scorecard I was showing, none of it was generated at the University of Waterloo. It was generated by CIHI using UW methods. Yeah.
I have another question. You mentioned the local health integration networks in Ontario, and the one piece that's missing from that is the physicians. They're the ones who order the drugs, tests, and admit patients. And I guess when I was a graduate student about 25 years ago, at U of T, one of the professors wanted to do a study on using OHIP data, demographic. I can't remember the details, and it was like no way, no how, never, ever, ever. And I'm just wondering, has that changed in the last 25 years, or is it, are we starting to get access to that information or that data, I guess, that OHIP data?
Yeah, I think that's really changed. It's still a closed shop for sure, but there are a number of us, and I'd be in that circle, who within the university community now are able to use that data under appropriate privacy regulation rules, link that data, and because you're absolutely right, physicians are gatekeepers of the system, and you and I can worry all we want about how much it costs to deliver a baby, but we're not in charge of that. That's happening in there with the person ordering the ice cubes.
Other questions? I don't want to leave anyone out. Ian, maybe you have questions you'd like to ask people here and get reactions. Anything that you would, anybody you'd like to pick on? Dennis, for example. He's darts.
Pick on Dennis. He's an ally. I guess, I won't place it as a question, but I'll place it as an offer to you. The University of Waterloo, through the research team that I'm involved with, is very interested in our mantra is this idea of we have a honking huge amount of data, the OHIP data, the patient abstract data, the financial data. And we're working to try and tease the evidence or the story that's in that data out of it. This is what our little logo idea stands for. And then try to build applications that deliver value out there. And the wonderful thing about the research team is that they're really interested in working on real-world problems. So those of you who have heard me today and say, my God, he's right on the money, and that's exactly the problem that I face, I would suggest that I would certainly enjoy buying you a coffee or a beer, whatever your preference is, to learn about the kind of decision-making processes that you believe are stumping you at the moment, and whether or not there's a role for university and the work that we do to deal with that. Because that's the wonderful thing about the team that I'm a part of. There's a great place for theoretical research, and I'm a high supporter of it, but I'm part of a team that's very applied and loves to work on the tough nut problems that people are actually doing. And Frank, just a heads up, I've just come back from something where I think XML is the only solution, and I'll be taking a problem that somebody gave to me off to Frank's office shortly. So we're a resource, I think. And same for you, Dominic, right? The university is a resource, and those of you who are out there should feel free to think about what are the current leading edge ones. One last thought, even on this, the research program I'm launching now for about the next year and a half is we're going to spend a lot of time trying to understand, if we can, how do healthcare managers and executives make decisions, and do these tools actually help them? I mean, is this just all nice fancy speedometers, but nobody really does anything different? If so, I should go on to work on something else, and it may well be. Or if it isn't helping them, why isn't it helping them? Is it because how we're presenting it, because the data is incorrect, because we're giving them the wrong information that they need? And we're very interested in our team in tackling those problems.
There's a great book by about Paul Erdős, the mathematician. It was called My Brain is Open. I guess we could summarize by saying our brain is open, and welcome the connection anytime. Ian, thank you. I'll turn this back to
Thank you very much.
Well, I'd like to give Ian a token of our appreciation. Thank you for coming, Ian. It's been a pleasure and a very interesting, very enjoyable talk, so thank you very much.
Thank you very much.
Now, there's one last item of business to do at this seminar, and I invite Fraser Edward to come down to the front. He's representing RIM today, or Research in Motion, or as he calls it, BlackBerry. And it's with delight to announce that we have a research partnership with BlackBerry, and that is it just started this year. And as a result of that partnership, Fraser and his company has very graciously agreed to provide a BlackBerry for each seminar as a draw for each seminar to the end of this year. So if you don't win today, you'll have other chances. Now, there are a couple of rules, and the rules are is that you have to pre-register and you have to attend. So, of course, I know that you're here, but we also have attendees coming in through the web, and they, too, have a chance to win. So I've got my high-tech data collection thing here, and I don't know whether I should mix things up, or I'll let Fraser do the draw, and so we'll call out the name, or I'll let Fraser call out the name. And we'll see if the person is in attendance or coming in through the web.
Raza Masood.
Masood, is Raza Masood here?
On the web, but not logged in.
Uh-oh.
Do we go for another? Or?
Yes, we go for another. So.
Well, we actually auction off 10.
Julie
Yoza?
Yoza? Yeah.
All right, we have a winner. Go ahead. So come on down. All right. Fraser, did you want to say anything, or?
It was another good session, so thank you very much.
Thank you. Well, we look forward to seeing you again next month, February 22nd. Come and join us for our next seminar. Thanks a lot and have a great day.